Fulfill function and disappear, how biodegradable magnesium implants can resolve clinical surgical practice. So if you look at materials, are stronger materials better to fulfill mechanical support, mechanical function? And permanent metals are very successful in the application, but do they also have side effects? And finally, how does biodegradable magnesium metal affect the surgical practice? Those are the issues I'm going to address in the following 25 minutes. Let's start with the first question. Is stronger, the stronger the better? For this, I'd like to show you a preclinical study with human-sized implants on mini-pigs, which we did a couple of years ago, where you see where we simulated bone fractures by applying osteotomies here to this is the eye to the orbit. So we removed a piece of the orbit and we fixed it with small implants. We cut through the zygomatic arch here, so 2 cuts here. And we cut on the other side of the skull, we cut afflicted with an oscillating saw, an osteotomy through the mandible. So these are the osteotomy lines which we used. In the upper part, so of the skull, this is not very much loaded. We used commercially available implants to fix those. So polylactide resorbable polymer for this, not the strongest bone, 70 megapascal. In the mandible, we used titanium implants from Synthes also, very strong implants, so let's say 700-800 megapascal in strength. And we compared that to magnesium implants. So the magnesium implants, we did not use the same, would have been unfair to use exactly the same geometry. We wanted to have the same fixation, so the same torque for the screws and the same stiffness of the plates. Therefore, we could make the magnesium, compared to the polylactide, we could make it thinner, so about 1.5 times thinner. Magnesium is about 3 times stronger than polylactide. And for the mandible, we had to make the magnesium a bit thicker. Titanium is about 3 times stronger than magnesium. It's also 3 times heavier. Here we used, instead, for example, of 1 millimeter thickness, 1.5 millimeter thickness. And we looked at the outcome with in vivo CTs to see the degradation, to see the healing of these fractures. So this was the outcome here compared to polylactide was quite similar. There was no significant difference. And also in the mandible, we saw healing. I have to admit that the number of animals was not really large to have really significant levels. Let's look at the second question. Do permanent implants have side effects? I have 3 examples from different medical fields. Let's start with the cardiovascular. So if you have arteriosclerosis, you have a narrowing of your cardiac arteries, you go in with a catheter, you expand the balloon, you destroy the plaque, and on top of the balloon you have this scaffold, this metallic scaffold, which is permanently, deformed and keeps your vessel open. Now in the long term, this can have a big problem, and you may end up with restenosis, so a narrowing again, necessitating another intervention. Or if you coat the stent with drugs, you have less restenosis, but you may have thrombus formation instead. In the field of osteosynthesis, if you fix bone fractures in hand and foot, you have small bones. You can fix them with small plates and screws or screws alone. But once it has fulfilled its function, sometimes you have to remove those, and this is not always easy. It can damage the surrounding tissue, which especially to titanium adheres very well. So, and in the dental field, I have another example of guided bone regeneration. There, you augment the alveolar ridge with a bone graft, and you cover it with membrane. Membrane separates the soft tissue from this. So in order to build up this bone, and when you come with the dental implant, you have to remove the membrane. But the membrane also is, if it's, for example, Teflon or so, sometimes you have infections and you lose your graft. So you have done the procedure for nothing. Let me categorize these drawbacks or these side effects according to these properties. If we look at biological properties, with permanent metals, you may have a risk of infection. Bacteria, even months or years after implantation, you may have an infection. Or we heard in the previous talk, allergic reaction with cobalt or with nickel-containing steels. On the mechanical side, implants, you dimension your implants a bit stronger, but you have stress shielding. The bone, for example, has no stimulus for growth if the metal is always the same mechanical level, and if the metal implant has to carry all the load, sooner or later you may have fatigue failure. Electrochemical wise, if you may have localized corrosion on steels, for example on sites where you have laser markings. And finally, on physical side, if you look at imaging, titanium and steel, they are cause artifacts in MRI, so you have a shade around the implants where you can't see what happened with the tissue. Now, the use of biodegradable magnesium metal can help to resolve some of these limitations. For example, the risk of infection is not there because the surface degrades and is no longer there. So you have no long-term infection risk. On the other side, allergic reaction are not a problem either because the magnesium alloys, the new generation, has only elements which are already in your body, like magnesium or calcium. On the stress shielding, I have to say that magnesium is much closer with the stiffness than titanium or steel. It has about 45 gigapascal bone, about 15 cortical bone. And what happens here is that with degradation, the implant carries less and less load. You also have a gradual transfer of load, and the tissue has to take over. On the chemical side, we have, with the new generation of alloys, we have a completely uniform degradation from outside to inside, not like polylactide where you have bulk degradation. And by the alloying, you can also, within certain limits, you can adjust the degradation rate. When it comes to MRI, magnesium has a similar density than cortical bone, and we have seen nearly no artifacts. So this is not a problem for magnesium. I'm working for RMS Foundation, and we do a lot of, we are independent, non-profit organization, and we do a lot of material testing. And we can assist you throughout the life cycle of your product. We also do research. We mainly on medical devices and implant materials, and we are been here for about 40 years. I'm going to show you some examples what we do it for in research and development. For example, we had a close collaboration with a client. We did a PO coating on magnesium. And the PO coating he used had an electrolyte with nasty substances in there. And we managed to make a lean electrolyte with substances which are like ammonia or like which are safer, much safer, and where the risk also for the patient was much less. For this product innovation, we could file a patent, which was quite useful for the client. So what we did is we used small plates, we deformed them plastically, and then we put them under tension. So this was a strong test for all coatings. So we plastic deformation and tension, and then we waited. We put them in SPF, simulated body fluid, waited until it breaks. Some coatings were not as good as the bare metal, but we had coatings which were better, so which could prolong the life. So the client here was quite glad to have a good solution. Next example, research we did recently in collaboration with ETH Zurich. Here we had this new alloy which was developed in the recent years, which contains only high pure magnesium with a little bit of magnesium of calcium. Used a rectangular specimen and coated them with the PEO coating, and did a number of characterization tests, which I'm going to show you. First of all, this is how we do the plasma electric oxidation. So we have, in our clean room, we have an apparatus like this with double volt electrolyte container. The implants are connected to the anode. We have a steel cathode. And we put, the whole thing is bathing in an electrolyte. We put a certain current. We set a current until we reach the given voltage which you want, and then we keep the voltage, current is going down. So the electrolyte we used was this linear electrolyte I just mentioned, which contains phosphate, ammonia, and urea. So very simple substances. We tested another one with contains also boric acid, and one with potassium hydroxide, named B and K. What we saw is when we changed voltage from 250 to 450 volt, the thickness increased from about 1 micrometer to about 10 micrometers. Also, coating mass was rising linearly, independent of for all electrolytes showed a similar behavior. What is not the same is, of course, the microstructure we got from these electrolytes. So some have smaller pores, some have larger pores, some have issues like this. What I have to say with PO coating, when you rise in current, you may have a formation of sparks. So these sparks are very hot, up to 5000 K. They melt the base material and they react with the electrolyte. So the coating is growing inside and outside and has an excellent adherence. That's a big advantage of these coatings. We looked at the coatings. We tried to characterize them first by surface topography. This is the topography of the plate without, you see still the machining traces. If we have a thin coating, the machining traces are still there. But the thicker we go with the coating, the more, the rougher it gets. So sorry, that was too quick. So you see RA values are rising from 0.2 to about 1.43. So this is where we get. Those are core roughness parameters. There are many more parameters, but I only show these. We also try to characterize them with X-ray photoelectron spectroscopy, so XPS. For this, we grinded the magnesium plate so that we have here position 1, we are on the base metal, and then we go across the coating. Position 8 would be here on top of the coating. What you see is that here, position 1, we still have metallic magnesium. We also have oxidized form of magnesium. But then on top of the coating, there is no metallic magnesium anymore. There's only oxidized magnesium. And if we look at the other elements, I did 2 graphs to be more visible. We have a lot of oxygen. We have a lot of phosphorus. So as a conclusion, in all of the 3 electrolytes, we have mainly magnesium phosphate, which is there. Then we did an in vitro degradation test with these coatings, and therefore we used a simple arrangement. We had an inverse measurement cylinder here, And this was in a bottle filled with 250 milliliters of SPF. And the whole thing is at 37 degrees in a water bath. And what you see here is such a plate. I'm just starting the movie. If I find it. Oh, now you see it. You see how this is non-coated magnesium. There are bubbles rising up here. You see them? And this is a degradation product of magnesium. So magnesium, 1 milligram of magnesium, which degrades, liberates about 1 milliliter of hydrogen gas. And after 3 weeks, so this is much quicker than in vivo. It's 3-4 times quicker than vivo, but these thin plates, after 3 weeks, they look, if you take them out and they are still wet, they look transparent. So this would be the initial side. This is the remaining traces of magnesium. So this is still metallic magnesium. If you dry that, it gets white, and you find that the powder you have is calcium phosphate. So magnesium, which you had initially, you end up with amorphous calcium phosphate. So the anorganic part of human bone, actually. We wanted also to see what stress corrosion has, what the effect of stress corrosion is on this. So if you insert a screw, the screw is under tension. So we did a torsion test. If this type of screw, this would fail probably at 60 to 70 Newton centimeters. And now we have here, we inserted a cylinder. So and we put this cylinder under compression, and the tension we could therefore, with this pressure sensor, we could measure actually the tension on the screw. The non-coated screw, it's quite, you see, you reach at a torque of 40 Newton centimeters, you reach 500 Newton of load. So if we and the PO coated, we reach it only at 50. This is because the coating is rougher and it has more friction with this plate. So in order to test them, we had to tighten the screws, non-coated with 40 and the PO coated with 50 Newton centimeters. We put them again in this in vitro degradation setup, which you see here. So the screw is here. It's compressing this peak cylinder, and this is the inverse measurement cylinder. And here we see the gas. We can measure the gas. What you see here is the released gas over time. So this is over 4 weeks. Every week we change the liquid. And you see that within 4 weeks, about 100 to 150 milliliter of gas. That means 100 to 150 milligrams are degraded. The initial weight of the screw is about 400 milligrams. What you see here is also that the coated ones has a lower gas release at the beginning than the non-coated ones. And as a surprise, we had no failures. I had, in previous tests, I had other alloys, and they failed relatively quick. And here, in the second series, we even pre-tensioned, we retensioned them, so we removed the torque to see how much torque is left, and then we retensioned them, so even a more severe test. Finally, we are also capable of doing electrochemical testing with an EC pen, so locally we can, this is like a felt soaked with saline, and then you run current through it, and you can record these, let's say, corrosion current curves. This is a logarithmic corrosion over the voltage. So you see the open, the potential at open circuit, and then you polarize the whole thing. So this is possible, but unfortunately here, the results are not good enough to correlate that with the in vitro degradation test. So to summarize, this RMS Foundation can support you with testing throughout the product life cycle. And we are also open, we're also a research company. We're open for research collaboration with strong competencies in degradable materials like magnesium and calcium phosphate. Now, this is the slide I showed you at the beginning. And I show you now the alternatives which are on the market made out of magnesium. For the cardiovascular, so for the stents, we had Biotronic came onto the market in 2018 or 16 with the first magnesium stent. Macmaris contained rare earths. Now they are just coming onto the market with a new stent, the Freesolve, which you see here with a tantalum marker, and it has no rare earths in it. It has some aluminum in there. Then Syntelix, they were the very first to come onto the market in 2014 with screws, but they're not very successful so far. There's another company up in Finland, biodegradable. They have, this is a magnesium calcium alloy, and they have an FDA approval for these screws. And for the membranes, it's maybe a product which you haven't seen yet. It's from Botis. It's called Novamag. They have a lichen magnesium sheet which you can deform, which you can cut, which you can adapt to the alveolar ridge, and which you can fix with these pins. And then over time, well, it separates the soft tissue from hard tissue, and with time it degrades, and then you can implant your dental implant. Finally, as a lookup, I like to draw your attention to a new startup company in Switzerland, which is Kairos Medical. They do suture anchors, PO coated. As you see, it's white. This is why it's white. And they plan FDA registration for next year. Some take-home messages. So the mechanical properties of magnesium alloys are adequate for many medical applications, are highly interesting. Magnesium implants can help to eliminate some of the major effects of permanent implants, so especially avoiding second surgery. So this has, as you see, an impact on surgical practice. With this, I'm in time, so
Thank you, Thomas. I will give the
Merci, Thomas. Nice job. I think it is working, absolutely no question, but there is a point I never understood with magnesium, and I hope you will be able to explain me why I am so stupid. We were speaking before about cobalt chrome, and we were all agree that it may be a good idea to eliminate cobalt chrome. And for metal, for knee application, for example, patient or surgeons try to measure the cobalt or chrome in the blood. And when the concentration is higher than X microgram per liter, they say, oh, it is dangerous, it is end of the world, and these kind of things. I am sure with the degradation or corrosion of magnesium, you should have a huge amount of magnesium in the bloodstream. And I'm just wonder whether it can cause any issue. Because if cobalt and chrome are seen to be so toxic, people are also saying titanium may be also question marks. When you have a concentration in the range of a few micrograms per liter. But I think with such a huge degradation, you should have not microgram per liter, but milligram per liter of magnesium. And I'm just wondering whether it can cause any issue.
Oh, that's a very good question. Thank you very much. So you were concerned that the huge amount of magnesium which is liberated could cause any issues. Is that correct? Yeah. So the daily allowance for magnesium is 300 to 400 milligrams. So if you drink a liter of water, you take up maybe 50 milligrams already. So and the amount of magnesium which is liberated here, it's a very light metal. For a stent is maybe 5 milligrams. So you liberate 5 milliliters in half a year. For the plates here, the thinner plates, you've seen the screw was 400 milligrams. These 400 milligrams corresponds to 400 milliliters, which are liberated maybe over 1 to 2 years. So that means per day you have maybe a milligram which is liberated. So I'm not so much concerned about the magnesium ions, because magnesium is needed for many biological processes. If you take a magnesium supplement, this is much more harmful than the implants we have here. I'm more concerned about people are more concerned about the liberated gas. So you have to be slow enough that the gas which is liberated can. Is that your second question?
Yes.
So for a stent, the gas is no problem. It's very little amount. It's in the bloodstream. It goes away. For the larger implants, it can be a problem. We see sometimes some gas cap formation around the implant, but it's mainly a problem for the non-coated ones, because they liberate a lot of hydrogen at the beginning, and with the coating you can make it much more gradual, the liberation, and so having less risk of cavities.
Thank you. Merci beaucoup. Dankeschön.
You're welcome.
Other questions?
Thank you to bring PO here. I'm very happy to see this topic. And I have a question. You say the corrosion is very everywhere and controlled. But when you do your treatment, you need to hold your sample. And do you have a corrosion issue where the sample is held?
That's a very good question. For example, if you take these suture anchors, you can contact them at the outside of the threads. So there will be, let's say, a very small area on the outside of a thread which is not coated, but it's not really an issue. You try to contact the implants where it's not critical. But it's not really an issue, especially if you've seen the comparison between coated and non-coated with these alloys. They are already very slowly degrading. These new generations really good. So but very good question. Thank you.
Any other questions?
What is the optimal thickness of your coating? And if you played with the thickness to see the other properties of your implants, I mean, have you optimized the thickness, or you just put the typical thickness in between and you don't care too much about the thickness?
Actually, I think it depends on the application. It depends on the corrosion resistance you need at the beginning. But I think probably the most of these coatings would work pretty well, even if they're not too thick. So usually there's an inner layer which is very compact, and then an outer layer which is more porous. Sometimes the porosity is an advantage if you want to have bone attachment, so the integration. So, but it's not. I haven't shown an indication where we have optimized the coating for it. So this is to be done for a given application.
Thank you a lot, Thomas, and thank you to Robert Mathis Stiftung for their support during these long years.